It's my pleasure to introduce Dr. Erling Falk. Erling really doesn't need much of an introduction to this group or to virtually any other group. He is one of the premier cardiovascular pathologists in the world, having made numerous contributions to our understanding of the pathology of atherothrombosis. And he's been very intimately involved with this initiative since its inception. And I cannot tell you the number of hours of email correspondence that he has had with Mort and many of us. And I have great admiration for his patience. And now, of course, dead people are not under any urgent time constraints. So for most of us, reading emails takes a lot of time away from patient care, but for Erling's patients can wait because in any case, Erling is going to give an overview of the shape paradigm, and he's spent a lot of time on this, so we welcome this opportunity.
Thank you, PK. In fact, I'm not going to give an overview of the shape paradigm, because the whole day today it will be by expert on their respective area of imaging, so I will not touch imaging. Rather, I will give a background of shape, why we are here today, why we have worked with this area now for so long time. 2 years ago, this consensus paper was published in Circulation from Vulnerable Plaque to Vulnerable Patients, a call for new definition and risk assessment strategies. Why? Because available screening and diagnostic methods are insufficient to identify the victims before the event occurs. Is it reality or is it a dream that we can eradicate heart attack? We know the causal risk factor for atherosclerosis and heart attack. We know that most heart attacks, in fact, are preventable. Nevertheless, atherosclerosis and heart attack remain the killer number one. It's a cause of severe disability, and it is very costly to humans and the society. So I think it's fair to conclude that apparently the traditional approach has failed. Causal risk factors are known. I would like to draw your attention to this marvelous atlas of heart disease and stroke. You can find it and download it for free on this website. Here we have the world distribution of blood pressure, and high blood pressure contributes to around half of all cardiovascular disease worldwide. Lipids, high cholesterol causes around a third of all cardiovascular disease worldwide. Smoking causes a fifth of cardiovascular disease worldwide. So overall, approximately 75% of cardiovascular disease can be attributed to conventional risk factors. And it is in fact in line with the InterHeart study published in Lancet last year, where it was shown that 9 modifiable risk factors could explain 90% of heart attacks in male and 94% of heart attacks in female. So we know the causal factors for atherosclerosis and heart attack. Most heart attacks are preventable. It's a background behind the polypill strategies suggested a few years ago that if you give effective treatment, you can prevent the expression of this disease. And it was postulated that, in fact, if you give effective treatment here, you can prevent 80% of heart attacks. So it is also preventable, but it remains the killer number one. It does worldwide, where coronary heart disease is responsible for 13% of all deaths. It is more than all cancer combined, 12%, and stroke is 10%. And, as you know, heart disease and stroke kill as many women as men. And here the US data, 38% of all deaths in the United States caused by cardiovascular disease, most by coronary heart disease, but 18% by stroke. Why then has our approach to prevention of this disease failed? We know the causes, We know the effective treatment, but it still prevails. Is it because available screening and diagnostic methods are insufficient to identify the victims before the event occurs? In this atlas of heart disease and stroke, there is also milestones in knowledge of heart and vascular disorders. In 1961, U.S. Framingham Heart Study investigator coined the term risk factors for the development of coronary heart disease. High cholesterol level, blood pressure, and electrocardiogram abnormalities found to increase the risk of coronary heart disease. So we know the causal factors, but does it also indicate, and does it mean that these causal factors are good predictors for those who will have heart attack and those that will not have heart attack? Wald and Law published a paper in Lancet more than 10 years ago, Apolipoprotein and Ischemic Heart Disease, Implications for Screening. The first sentence, apolipoprotein and lipids are established risk factors for ischemic heart disease, but their efficacy as screening test is not known. And they evaluated this efficacy in more than 20,000 UK men. And they found that there was considerable overlap in the distribution of ApoB and cholesterol among those who developed ischemic heart disease and those who did not develop ischemic heart disease. They evaluated the relative odds between individuals at the 9th centile versus those at the 10th centile. And although the relative odds were 13, a high risk, then lipids were poor screening tools. They were able to identify a high-risk group. It was small at the upper end of the distribution, and a low-risk group at the lower end of the distribution. But the great majority of heart attack occurred in the middle, the majority of the population. And in that part of the population, you could nearly as well flip the coin as measuring risk factors. So they conclude that these risk factors are poor to discriminate among those who will develop disease and those that will not develop disease. And it is not advisable to screen for ischemic heart disease by measuring any combination of cholesterol, ApoB, ApoA1, ApoA, and the other risk factors. And it was the background for the suggestions of the pulley pill strategy. If we cannot identify those that need treatment, let's use the age, because with age, the increase of getting a heart attack increased dramatically. So it's what we have, and it is what we use today. It is Framingham risk factor scoring to try to find those that need treatment and avoid treatment of those who don't need it. It has been tested in population outside Framingham to assess the ability of a test to discriminate between those who get the disease and those who do not get the disease. You can measure the area under the ROC curve. And if the area is 0.5%, there is no, and if the area is 0.5%, there is no